Good morning. Please welcome to the stage the Director of the CDC's National Center for Chronic Disease Prevention and Health Promotion, Dr. Karen Hacker.
Good morning, everyone. And welcome to the second day of the Dementia Risk Reduction Summit. So as you just heard from the word on high, my name is Dr. Karen Hacker. I'm the Director of the National Center for Chronic Disease Prevention and Health Promotion here at CDC. And I'm very excited to be here today to share the work that we are doing in chronic disease that relates to dementia risk reduction. I just want to thank the Alzheimer's Association for hosting the first national meeting on dementia risk reduction here at CDC. And I want to thank the staff of the Division of Population Health and our Alzheimer's team for working with the Alzheimer's Association to plan this meeting. It's really a great event to see you all here today. I think we're all starved for interpersonal relationships in person, and it's wonderful to see so many folks were able to attend. So CDC takes a collaborative and coordinated public health approach to reduce or delay the risk for cognitive decline and dementia, with an emphasis on improving the quality of life for those with dementia and those who care for them. This new 5-year award will have an emphasis on ADRD risk reduction, early diagnosis of ADRD, prevention and management of comorbidities leading to preventable hospitalizations, coordinations of community services, caregiving for persons with ADRD, health equity, social determinants of health, and community clinical linkages. The collaboration of awardees from the National Health Brain Initiative, the BOLD Centers of Excellence, the BOLD program recipients, and the work of CDC is strengthening the public health infrastructure to improve the health, well-being, and independence of persons living with dementia and their caregivers. The addition of Goal 6 in the National Alzheimer's Plan also allows us to ensure that we are focused on primary prevention. This is an enormous step for all of us. I cannot say enough about it because it changes the conversation. I think you all know this already, but you have to understand, for us in the Chronic Disease Center, this changes how Alzheimer's is related to everything else that we do. And it really connects the dots for chronic disease and Alzheimer's as a major chronic condition. We know that what keeps the body healthy can also keep the brain healthy. And many of the same risk factors that cause or worsen chronic diseases are linked to Alzheimer's and related dementia. And that connection, as I said, has really changed the conversation. The behaviors that lead to chronic diseases and the people often who have one or more of those chronic diseases can complicate the management of their existing health conditions, and now we know increase the risks of Alzheimer's and other dementias. So many of the evidence-based activities that support prevention and control of chronic conditions that include things like managing hypertension, promoting physical activity, eating healthy, serve as potential strategies for ADRD risk reduction. And at CDC, we promote chronic disease prevention in particularly 4 areas. We measure how Americans have chronic diseases or chronic disease risk factors. We try to improve the environments to make it easier for people to make healthy choices. We strengthen healthcare systems to deliver prevention services that keep people healthy. And we connect clinical services to community programs that help people prevent and manage their chronic diseases. This approach to preventing chronic disease and promoting healthcare can really help achieve the Chronic Disease Center's vision of healthy people and healthy communities. So, since 2005, CDC's National Healthy Brain Initiatives have been addressing cognitive impairment, including Alzheimer's disease and related dementias, or ADRD, and supports the needs of caregivers. And this initiative has now expanded. We've created partnerships, enhanced data collection and reporting. We've increased awareness and promotion of brain health, and supported implementation of our roadmap series. The roadmap charts a course for dementia prepared future and is comprised of 4 essential services of public health: to monitor and evaluate, to educate and empower, to develop policies and mobilize partnerships, and to assure a competent workforce. And as many of you know, the Building Our Largest Dementia Infrastructure for Alzheimer's Act, or the BOLD Act, was passed into law in 2018. And although our center was already focused on public health approach for dementia through the Healthy Brain Initiative and the Roadmap series, the BOLD Act and subsequent funding allowed CDC to accelerate the pace at which we work with state, locals, areas, and tribes. I don't know if you all know, but I've only been at the CDC for about 3.5 years. And I think, as I was saying, we really didn't get our first major line item until 2019, 2020. And that has grown every year since I've been here. I think you all deserve a pat on the back for that. The activities outlined in BOLD are designed to create a uniform national public health infrastructure with a focus on increasing early detection and diagnosis of dementia, risk reduction, prevention of avoidable hospitalizations, supporting dementia caregiving, and increasing timely analysis and the reporting of data. And so as a result of that BOLD Act, CDC established the BOLD Public Health Centers of Excellence, and these centers support the implementation of the Healthy Brain Initiative. They work to identify, translate, disseminate best practices across state, local, tribal, and public health programs. And to accomplish this, we've funded 3 public health centers of excellence that support dementia caregiving, early detection of dementia, and dementia risk reduction. So as you can see, there is a tremendous amount already going on. And our approach to preventing these chronic diseases and promoting health can help achieve our center's vision for healthy people living in healthy communities. Since many of these risk factors for dementia are the exact same risk factors for the other chronic diseases, as I noticed earlier, we are really trying to address these across the continuum. So at the same time as our chronic disease prevention and health promotion is deeply rooted in advancing health equity and addressing the social determinants, we are now seeing that these are as related to Alzheimer's and others dementias as they are to all of the other chronic conditions. We know that some racial and ethnic groups in the United States are more likely to experience worsening memory loss than others, and that can be a precursor to other dementias. And that may be due to non-medical factors that increase their risk, such as where people live and their access to a variety of social and economic benefits. So these are sometimes called the social determinants of health, or the conditions in which people live, work, play, worship, etc. They can include things such as isolation, loneliness, racism, financial hardship, limited access to transportation or healthy food, and affordable housing. And this also includes one's ability to receive dementia care and support services in their own communities. Stigma and cultural differences, awareness and the understanding about dementia can all lead to health disparities and adverse outcomes. And there's going to be a much more robust discussion on just this topic at the panel discussion later today. The information that's being shared in this summit and the work you all do to enhance this work can only help those who are affected by or at risk for developing dementia. But they're also going to help in the risk reduction of diabetes and heart disease, stroke, and cancer, as well as a myriad of other chronic diseases. You are improving the overall health and independence of people as they age. You are helping 6 in 10 adults in the United States who have chronic disease, and 4 in 10 adults in the United States who have 2 chronic diseases. So, on behalf of our center, thank you for attending this important conference today. And as we move forward, a focus on evidence-based interventions, community clinical partnerships, health equity, and impact evaluation are going to be key in preventing future cases of ADRD and in improving the health and well-being of all persons in America. I am excited about the work that you are doing and the contributions that you are making for chronic disease and dementia risk reduction. And I really want to say thank you all for coming today, for participating in this conversation, and helping us move the agenda forward. Thank you.
Please welcome back to the stage Summit co-chairs Dr. Wayne Giles and Dr. Jewel Mullen.
Okay, you can tell we didn't coordinate this morning. I don't know. We're getting more comfortable to decide who was going to go first. So let me just start off. Good morning, everyone. It's great to see you. I want to thank Dr. Hacker for her great comments and getting us started this morning. I hope you all had a restful evening last night and were able to get some time to recharge. One of the things that I really loved about yesterday was sort of after the panel, the conversation and the discussion that we had. And so I'm hopeful that that will continue part of the theme for today as well. Because I think that exchange is sort of also part of where we all learn and really get sort of those really important take-home messages that I think are so important. I think there are a couple of things that I just wanted to reinforce. One was, I know while our funding is siloed, we need to think about the communities that were served and the fact, right, that they are, as Dr. Hacker just said, impacted by multiple chronic conditions and diseases, right? So we need to think about the fact that an individual is not going to just have hypertension or diabetes or heart disease, but it's really that combination that they're struggling with. And I think our interventions need to think about that. I think it's the other important theme that we need to remember is when we ask older people what they fear most around aging, it is this loss of cognitive function that they really truly fear. And we need to use that as a potential motivating force for our interventions in the work, because that provides an opportunity as we're working with healthcare, et cetera. So I think that's an important message as well. Today we're going to continue down the spectrum of prevention, and we're going to start off with policy, and sort of you've got a great panel there, and then we're going to talk about both community and individual education. So, and then the final session today, which is, I think will be really exciting. Well, I think all of it will be exciting, but the final session will be focused on social determinants of health. And we've geared that to be more of a discussion than individual presentations. And I think that'll be great. So with that, I'll turn things over to Jewel.
There's not a lot more I can say other than good morning. If there's people came here with so much momentum, and if there's any notion that like momentum builds a movement, then I hope that by the time the day ends, you feel like we have even more of a movement going on. And as former ASLO president, I can tell you I've been walking around to people in different state health departments saying, I don't know your commissioner, but if you want me to email them and like promote what you do, I'll do that too. So think about all the different ways in which you can support one another, and we can support one another across the country on behalf of people across the lifespan, so that there's still something left by the time we start thinking about older adults who, if we look at diabetes, colon cancer, and so many other conditions that we thought older people get, things are happening earlier and earlier in life. So it's all important. Matthew reminded me that it's World Hypertension Day. Yesterday, somebody said hypertension is a big risk factor. We might hear some more about that today. So this notion of fear, anytime I can get people back to thinking about there's something that you can do about the things you fear, then that's another important message that we all spread. And then I think finally, all I would say is, and I'm going to say this again later in case some of you have to leave, these 2 days, and thank you to all of you who have said how great it's been to be here so far, they're not just a moment in time. They're really not. So take that with you, even when you go back and say, it was so nice, but I still don't have money. It's so nice, but they still won't collaborate with me, or whatever you say when you get back again. Because, if you talk to people, a lot of us have been in this for a long time and we're not going anywhere. So there's nothing much more I need to
I think we're
say
good.
other than I am really happy to then introduce Dr. Amy Eiler from the Washington University in St. Louis for our first session on policy and legislation.
Good morning, everyone. I absolutely love presenting in the morning. Everyone is energized and caffeinated, so thank you for that response. And I have to say, this is my third in-person conference since COVID, and everyone I appreciate and value so much. So I hope you do too. All right, let's get started here. We have top-notch experts on the panel who give some really great examples of policy and legislation, which is the topic today or this morning for this panel. And I am so excited, but a little bit intimidated because yesterday was so awesome. But I know that this group is going to really pull it out and get you energized this morning about policy and legislation to reduce the risk of dementia. So first, I'd like to introduce Lori Witzel. She is the National Vice President of Policy Research for the American Heart Association, helping to translate science into policy at a national level for heart disease and stroke prevention. She'll be talking about a project to make physical activity assessment, prescription, and referral a standard of care in the U.S. healthcare system. Next, we have Dr. Hector Crosco, who is the Health Equity Director in the Family Health and Wellness Division of the Tennessee Department of Health. He'll be presenting on some state-level policy efforts related to healthy aging and brain health. Next, we have Sarah Lenslock, who's running a little bit late, but she will be here. She's the Senior Vice President for Policy and Brain Health in AARP's Policy Research and International Affairs Group, and she'll be talking about community solutions and the livability index to sustaining brain health in communities. And then we have Sarah Blenner. She's the Director of Field Studies and Applied Professional Training for UCLA Fielding School of Public Health, Department of Community Health Sciences. She'll be talking about how to enhance stakeholder engagement for policy advocacy. And I did notice you were an Emory grad, so welcome back. So before we begin, I want to talk a little bit about policy and why it's so important for public health and reducing dementia risk. But I do have a disclaimer. I'm a physical activity researcher, and many of my examples will be about policies in the built environment and how they relate to activity. But this is still really relevant to dementia risk reduction, as 25% of the adult population do no physical activity. They are physically inactive, and that prevalence only increases with age. So it's a very important risk factor, and the examples I give you will exemplify that. So I have a question for you. I know it's only 9 o'clock or whatever time it is. What public health policies did you encounter today? There's a good chance that you had some behavior or action that was related to policy. So think about that for a minute or a couple seconds. And then I want you to turn to your neighbor and just exchange answers, just really quick. Get some conversation going in the group. All right, that's great. I love the chatter. Lots of good policy excitement this morning, which is great. So maybe you had some water today. Clean drinking water, safe drinking water, the result of policy. Maybe you needed a little bit of assistance getting in the building today. We can thank policies such as the Americans with Disabilities Act that made that possible. Maybe you took public transportation today or had a choice of which way you got here today. Those are all policy related. Clean indoor air. Thanks, policies. Were you able to walk or bike safely in your neighborhood? Safe. That is related to policies as well. Healthy food access. Policies can influence that. So it is such an important part of improving public health in all these aspects, which can relate to reducing dementia risk. So what do we mean when we say policy? There are people who love studying policy, and there are people who run away when you say policy. But it's so important to understand what we mean. And there are many definitions of policy, but since this isn't a semester-long class, we're just going to do it in one slide. People put it into two buckets. Big P policy or public policies. These are formal laws, rules, and regulations enacted by elected officials intended to influence behaviors, actions, decisions of others. So those are the formal policies, and that's what most we're going to talk about today. But also important are organizational policies. These may not be enacted or on the books, but they're still really important. Things like worksite policies, rules and practices, and sometimes normative behaviors in specific settings can become policies. So why are policies so important to improve health? If we had $1 for every time we saw this figure, we would all be able to pay for dinner, right? This is the socio-ecological framework, and it is very important because it's such a key way of framing these complex health issues. So as you can see, public policy is the outer layer of the onion. It kind of looks like an onion to me, but it's still very connected to all the other layers. Again, these complex public health issues require complex solutions. We won't reduce the risk of dementia with a single level approach. It has to be all encompassing. Policies can affect environment and behavior to reduce risks. And for those of you who took health behavior theory, we know that this is very important in enabling healthy choices. Policies can reach large populations. Think about a community that requires sidewalks in their communities. This is going to impact every resident of that community and every resident for a long time by enabling safe routes. Policies can also alter social norms. Think about that clean indoor air and smoking policies. As smoking policies became more prevalent, smoking prevalence went down, and it's just not that socially acceptable to smoke anymore. Although we're seeing some reverse of that with marijuana legalization, but we'll be talking about that in another meeting. And policies are sustainable. Once they take a long time to be introduced, enacted, implemented, funded, but they're sustainable and they can impact multiple generations when in place. So policies sometimes are very intricate interplays among these different levels. We have federal funding, we have state laws, we have local municipalities, we have even school districts can be thrown into this mix. But a lot of times a wrench gets thrown in, and policies like preemption, trigger laws can really make a difference to our efforts, and we have to be aware of those. This is a pretty simple description of the policy process, but it goes from agenda setting, formulation, adoption, implementation, evaluation, maintenance. We can intervene and advocate at any of these different levels and still have an impact. So there's lots and lots of work to do. But we do need to consider a couple things. First, competing priorities. We all know what that's like in public health. Lots of competing priorities that are going after our programs and our funding dollars. The people within the community can make a difference. The culture and the F-word funding. All of these can be important parts of our policy advocacy and the ways in which we can improve population health with policy. So I've been doing policy research related to physical activity and obesity prevention for about 20 years. So in preparing for this presentation, I was really reflecting on things kind of I wish I would have known earlier that would have helped my job. And so I'd like to share, I'm calling them policy considerations that maybe can be very applicable to your work, and you can relate it back to what the panelists say. First of all, we all live in these democratic laboratories. And it was a book by Andrew Karch, who wrote about how individualized these places where policies occur happen. And even though we don't create Frankenstein in these policies, there are a lot of places that policies can be made and activated to improve population health. Think about it, 50 states, all with different policies. Over 3,000 counties in the US may have different policies, may be similar. 30,000 incorporated cities, and that doesn't even count rural areas or the smaller towns, and 573 sovereign tribal nations, all with different policies, sometimes competing, sometimes working together. But the good thing about these democratic laboratories is that we can compare and contrast. We can learn from each other. What worked? What didn't? Are you like me? So if in St. Louis we compare ourselves to LA or New York, our lawmakers will kind of shun that. But if we compare ourselves to cities that are more like St. Louis, then they might be more likely to listen. Same thing about states. So looking at state similarity. I have livability index on this slide too, because it's a great resource, and Sarah will be talking about that later, that you can use that information to compare and contrast what's happening in different places. And the National Conference of State Legislatures is also a great resource. You can type in any kind of policy where policies exist and get a list of states and what's in those policies, when it was passed. And there's nice links that click back to that state policy so you could look at some of the determinants of what helped that process. This is an example of the diffusion or policy diffusion that these democratic laboratories take place. So this is municipalities with complete streets policies in the St. Louis region. Complete streets policies say that roads must accommodate all users, pedestrians, bicyclists, those who drive and those who take public transportation. And these are really important in making our communities walkable and safe for pedestrians and cyclists. And so in St. Louis, you can see how these little dots cluster together. One community looks at another and says, oh, you have a complete streets policy. Maybe we should. Sometimes they do it for connectivity of these things, and they can share some resources. Sometimes it's social desirability or economy. Maybe someone will select a community with a walkable neighborhood versus another one. So this is a good example of how these policies can spread based on what other municipalities may do. The second consideration is the concept of evidence-based and evidence-informed policy. We often talk about evidence-based interventions, but a lot of that rolls into policy as well. We have this huge gap between what's needed and what's available evidence related to how policies impact population health. And it's often seen as a similar continuum as we see in the community guide. Very effective. We know that indoor smoking policies help promote clean indoor air. But there's other ones that are promising that we don't have the specific evidence for. And then some are just untested. And we often look in three domains when we look at evidence-based policy. We look at the process. What goes into the policy? What approach increases the likelihood of adoption of an evidence-based policy? And then there's content. Identify specific policy elements that increase its effectiveness. We know what increases physical activity in kids, let's say in physical education. We know what needs to be in these policies. So figuring out if having these elements increase adoption or not and increase the effectiveness is a really important thing to do when you're looking at research of policy. And then there's outcome. How to document the potential impact of that policy. This is a great piece to sell what you're trying to advocate for, and it's often very difficult to do that. Here's two examples from my work. We looked at predictors, patterns and predictors of enactment of legislation to reduce childhood obesity. And this was several years ago. We looked at all the policies with anything to do that might reduce childhood obesity. And we looked at who introduced it. What were the characteristics of the legislator that introduced these bills? We looked at characteristics of the state in which the legislator was and the legislation was being proposed, whether it was enacted, and then did all kind of multi-level analysis to look at some predictors. And some of the things we found, no surprise, bipartisan sponsorship was one thing that increased the likelihood of enactment. Also, term limits in states. It seemed like legislators were more likely to take risks at potentially unpopular things when they had term limits in their states. Also, topics like safe routes to school. That was an easy one to enact. It seemed very, benign to legislators, but you talk about menu labeling, or sweetened beverage, sugar sweetened beverage taxes, those were less likely to be enacted. So by doing this content analysis, we can pick and choose, and by learning what might influence the likelihood of enactment, we could advocate for those things, or maybe do a deeper dive into things that might not be as likely to be enacted. Another study we did, we looked at all physical education legislation over a period of time, and we analyzed it for evidence base. We looked at 4 pieces of evidence that we know that improves children's physical activity and fitness in schools, and we searched 782 bills to find out what types of evidence were in the bills. And of those 782 bills, only about 270 even had one piece of that evidence. So this is very telling. We need, as public health practitioners, we need to influence that policy process by talking about why that evidence is important in these policies, because then that will improve the outcome and effectiveness. One thing I did learn, and I was thinking about this when reflecting on this project, is there are so many not evidence-based policies. So in Missouri, there was a policy that was introduced 4 years in a row to make the jumping jack the official exercise of Missouri. After 4 years, it finally passed. Do you think that will increase? Everybody get up and do a jumping jack. And apparently it was invented in Missouri. I don't know. But this is not an evidence-based policy. Maybe it increases awareness of physical activity and jumping jacks, but unless you require people to do hundreds of jumping jacks a day for 20 minutes a day, 30 minutes a day, it's not evidence-based. So there are lots and lots of policies out there that are made that a lot of effort is put into, but it could be better. We have opportunity for improvement. And lastly, the last consideration is policy de-implementation or de-adoption. Sometimes policies need to hit the road. They need to leave. They don't work, and we have years and years of showing that they don't work. So think about a program about drug abuse that didn't work, but was still in play for a long time, the DARE program. But there are lots of policies like that too. And then on the reverse end, sometimes effective policies are removed and they continue these ineffective policies that should end. So this is an issue in the policy realm as well. And so just a quick example of that in St. Louis again. St. Louis has this policy that they'll help neighborhoods improve their sidewalks. So St. Louis is an urban area, and it has lots of infrastructure problems, lots of different little neighborhoods. And so the city put forth this policy. It's called the 50-50 sidewalk program, where they will pay for 50% of the sidewalk repair in the front of your house. So sounds like a great idea. Everybody jumped on board, but it doesn't work. It's been around since, 2015. Right now, there's 1,800 people waiting for sidewalks. And over 200 of those have been on the list since 2017. So it's not working. And not only is it not working, it's not working for certain groups of people. So this is a quote by one of our aldermen from one of the neighborhoods. This policy is unfair. It most serves those who have the wherewithal to complain and the money to pay their share of the cost. The city's more prosperous southwestern neighborhoods and the sidewalks are falling apart all over North St. Louis and Southeast City. This is not going to change sidewalk locations in our neighborhood. So this is an example of a policy that needs to go. It needs to be replaced by something better. So what did we do? We looked at other cities who have better programs, and then we're presenting that to the mayor's office so they potentially can improve not only the policy, but the outcome of this policy. So in summary, while it's messy, it's complicated, policy advocacy is worth the effort. It's going to be your legacy because once it's enacted, it'll be there for a while. And we have to consider the process and all its complexities, all those places where you can intervene and advocate. Compare and contrast for solutions. I gave you some resources to look up different places where you can show the data to people who make those decisions. And then learn more about effective advocacy. And wow, you have that great opportunity today with our panel. So I look forward to our panelists and what they have to say, and then we'll circle back around and have more of a discussion. So first on the docket is Lori Witzel.
Thank you, Amy. I'm tempted to start off with some jumping jacks just for fun. So it's really great to be here today, and it's a wonderful opportunity to tell you a little bit about the work that we're doing in alliance and coalition and collaboration. I understand that was a big theme yesterday, and it's something I'm living every day and bringing people together and trying to get something done, policy and systems change done. And so today I'm going to talk to you about our It's Time to Move initiative. And this is our effort to make physical activity assessment, prescription, and referral a standard in U.S. healthcare. So it was about 4 years ago that we brought the physical activity community together in Washington, D.C., with the idea of perhaps trying to unite the community more and try to speak with one voice on policy and systems change. There was a lot of support in the room to make that happen. And so we spent the next year building trust amongst organizations and key experts and folks in the field. And it took that year to bring everybody together into the 501c3 that is now the Physical Activity Alliance. And I'm really proud of that because it is an amazing talking point. It's how I usually open presentations with obviously conferences here, but like this one, but also with key change leaders and policymakers. The fact that we've brought the community together and we're trying to speak with one voice gets their attention, and that's impactful. So our mission is really to promote physical activity across the population, but really focus on the policy and systems changes that Amy talked about. I have a similar slide deck to hers, and it was just refreshing to hear her talk about evidence-based policy making and kind of the nature of the policy continuum. I've lived that in my career, and it's an exciting opportunity to take the evidence base and translate it into change that hopefully will impact population health. But we have 17 board level organizations now in the Physical Activity Alliance, but we reach probably nearly 100 across all the work that we do. We have the top researchers in the field connected with the National Physical Activity Plan, which is the roadmap for implementing the physical activity guidelines for Americans. And so we have a memo of understanding with the U.S. Department of Health and Human Services so that we collaborate and coordinate across the work that we're doing. Us working on the National Physical Activity Plan, implementing that, and staying in touch with all the great things that the U.S. government agencies are doing right now. So a number of our initiatives, I'm going to focus in on It's Time to Move today, but I will mention that we have the Congressional Physical Activity Challenge happening right now. We have over 400 members of Congress and their staff participating in a physical activity challenge. We'll give you the results at the end of the month. We'll be promoting them. But right now, I think that, well, I'm not going to say, I think that it's Republicans edging out the Democrats, and it's great. It's a lot of fun, and but more importantly, it's our opportunity to get physical activity, our messaging in front of lawmakers in a fun way. So our It's Time to Move initiative is a multi-year, multi-pronged effort. What we're doing is really standing on the shoulders of all those who've been working in this space for so long and trying to bring a new sophistication to the policy and systems change work. And so we are interacting with a number of government agencies, 501c3 key, change leaders in the space, new stakeholders that I have not talked to in my career until now. And that is like the data analysts, the health systems, the CEOs, et cetera, that can make things happen. Payers, obviously the payer community. These are folks that we have to bring and invite to our table if we're going to really make this happen. And it's been exciting. I have learned something on every day of this journey. We're talking to new stakeholders, learning what we need to do to make this happen, help make this happen. It's a big effort. But I'm going to take you through. So do not look at all the details here. I'm just going to use this slide as a point. My point here is develop a roadmap before you get started. Talk to the right people and craft a way forward that gives you a sense of what we need to accomplish to get underway. That has been incredibly valuable to me as we think about the different prongs of this plan and how to sequence everything. There's a sequence to the work that we're doing, and it's what we're doing right now. So I'm going to say the first thing we had to do in that sequencing is build the foundation. So what I heard, and this all came about actually in a conversation with the CDC and with the national academies as COVID was getting underway, we were talking about surveillance systems. And somebody made the comment, well, we've been working on improving physical activity surveillance systems for quite some time, right? But somebody made the comment, you know what would really help here is if we had an HL7 measure for physical activity. How many in the room have worked in HL7 or know what HL7 is? Awesome. Okay, I will admit that I did not when that comment was made. I had not worked with HL7. And so it took me, I had to kind of get up to speed and say, okay, what's involved here? What do we have to do to get an HL7 measure for physical activity? Why is that important? HL7 is an international 501c3. They create standardized measures that can be exchanged within health systems and between health systems and community-based providers. They make things work. They make the data exchange possible. And what HL7 creates goes out into the public domain, and it is being adopted in federal regulation. So by working in HL7, we build the foundation for measuring, all of us measuring the same thing in physical activity surveillance. It's not only are we trying to improve patient well-being and patient care, but we're also a supplement potentially for the national surveillance system. So that's why CDC has been a really key partner in all this work. I'm going to cut to the chase. It's been about a year and a half. We have now just gotten our implementation guide through ballot approved. We're reconciling comments. We hope to publish it by this summer, 2023. That will be a guide, and we'll be, putting it into practice now for the next few years and refining it and get it to final version in about 3 years. But this is the foundational guide to put standardized measures into healthcare delivery. Which is really critical. We're also talking to the Office of the National Coordinator. We applied last fall to have physical activity assessment incorporated into the U.S. core data for interoperability standards. Wow, that's a big mouthful. It is really important because the ONC develops minimum standards that all electronic health records have to have and be capable of exchanging. In July 2023, we'll find out for sure, but it looks like we might have physical activity assessment incorporated into those core standards. That's another big step forward. Friday, I'm talking to the National Committee for Quality Assurance, and we've been talking to them about performance and quality measures because you have to incentivize payers, health systems, and providers to have the conversation to see if patients are physically active and help support them on that journey toward active living. And if they have, that they're paid more when they have those conversations, if we get the performance and quality measures right. So we're talking, NCQA is very excited about our implementation guide in HL7, and we're talking to them about adopting it into some of their work and hopefully getting to a performance and quality measure that can be used across healthcare delivery. And then the next thing that we're going to do now is start to work on a payer strategy. We're going to work, I hope, with a firm that's going to help us build a roadmap for engaging the payers to pay for the exercise prescription and what that might look like and how might we break into that ACO market or employer-sponsored health insurance market. So this is the next year's focus. So you can see the sequence to all this, right? And that's why that foundational work that we've been doing over the last year is really important, but it helps us build toward that ultimate end goal, our North Star of making this a standard of care. It's a lot of work, and we have to get health systems now to implement the implementation guide, right? That is not an easy lift, let me tell you. And we may have to look for funding sources to inspire them to at least get that underway. So that's the other thing I'm working on. I'm going to slip through a lot of this because I just want to say, and I think these slides will be shared with everybody. If you want to, come in and see what we're doing with the project, these links are all here. I would invite you all, if anybody in this room wants to join us, we are a big table. Our table is increasing in size, and I just want to be inclusive. The work that you're doing is incredibly valuable and would contribute to what we're trying to do. And we could maybe collaborate and coordinate across all of this. So just want to say, if you're interested, come talk to me. We'd love to connect you in some way. I'm just going to skip over these next slides to because this is it gets really wonky, and we don't need to get into that. But I will say this: the evidence base is really important. Just yesterday, we were having a conversation as we reconcile comments in the implementation guide. We had some that were pushing back on some of the measures that we were using. And we were able to say, no, we were aligning with the physical activity guidelines for Americans and the evidence base. And that is why we chose what we did. And they were fine with that. But it is critical that we do evidence-based policymaking. So our core measures and the work that we're doing across the continuum of patient care is all based on the literature, the evidence base, what we've seen so far in terms of impact. So that's important. I just want to say too that talking to different stakeholders and coordinating across the agencies is so important. One of the reasons we were successful with ONC is because the White House wants to see this happen right now, coming out of the White House conference. That was great. And also, friends at CDC were willing to send an agency-to-agency letter to ONC saying, you know what, this would be really great and important for our surveillance work. And CDC was also important in the advisory committees to ONC. So all to say, this conversation that's happening right now between the agencies, between the White House and agencies, it gives us an opportunity that we need to take advantage of. We can't miss out on this key opportunity to leverage the White House conference momentum. What I've learned in policy and advocacy work is when you have the opportunity, take it because it may pass quickly. Our political environment, the political backdrop to all that we do is constantly changing. And so all to say, those conversations are really critical. And I'll just say again, please connect with me if we can work together in any way. Thank you for the opportunity to be here, and I look forward to our conversation.
Thanks so much, Lori. And I know you've been doing this work a long time, and it has taken so long to get where you are. So congratulations on having that progress. So we're going to go a little bit at a different level into a state level, and Hector is going to talk about some things happening in Tennessee.
Good morning, everybody. When I was hearing Laurie talking about physical activity and physicians prescribing that, it reminded me when I graduated from medical school, I started working in rural communities in Chiapas, Mexico, just in the southern border with Guatemala. And I remember that when I started my community, 54% of the kids had malnutrition. And I was like, what am I going to do? Do I prescribe antibiotics every time that a kid comes with pneumonia or diarrhea? Or should I do something to solve the problem? And we found an organization, Jefe International, that came with a bunch of chickens. And then one day I found myself prescribing chickens to the kids. And I think that, well, half of the chickens died the first week. That's another story. But I think that the important story is that the medical system, it has been a lot about throwing medications and quick solutions to big social problems. And now we're talking about real policy change. And I think that's what is exciting about this conversation. So I really appreciate the invitation to this summit. I appreciate all the organizers that have been putting a lot of effort to put this together. I know it's not easy. And dementia is a personal topic for me. My grandfather, my hero, died from Alzheimer's in 2018. And it's really hard. It's really hard to be there to see his body of the person that you love the most, your champion, your hero, but his mind is not there. And it's just his body was just a reminder that this wonderful man existed or exists. It's a difficult distinction, but it is a personal topic, and I do think that we have to be doing more things in this topic because certainly for the family it is really hard. We have the best physicians, the best medical centers, and still it's really hard to win the war against dementia and clinical institutions. We have to go to policy change. And well, now when I received this invitation, I was wondering, is like, what health departments actually do to influence policy and legislation? And guys, how many of here are coming from state health departments? Can you lift your hand? Wonderful, wonderful. So let me just say that there are. I hope that my presentation will help um, to inform some of the practices that you guys are doing. And I'm sure that Tennessee has a lot to learn from what you guys are doing to influence policy, especially in these crazy, crazy times. So the history, and I'm gonna provide some examples, some of the examples that the work that has been happening in Tennessee since 2017 around dementia, around Alzheimer, and it's really important for me to acknowledge that the office that has been really advanced in many of these efforts is our office of patient care and advocacy. And we have here Chelsea, we have Sally, who have been working really hard to promote these efforts. And I think that this is one of the main things that, one of the main takeaways of my presentation. It is important to have people committed to advance these topics and organize different government agencies. So let me move on to this to describe each of these efforts. So these efforts started in 2007, when for the first time in the history of Tennessee, we had a task force that was devoted to examine the problem of Alzheimer and dementia. And it was mandated by the General Assembly. And in this report, the problem was described as we have around 100,000 people in Tennessee suffering from Alzheimer, and also there is a moral, this isn't a moral argument, but also an economic argument. Across the U.S., 148 billion are being spent in unpaid medical care, like unpaid caregiver like costs, and also medical costs and so forth. So definitely a huge problem for the people in Tennessee. And there were a bunch of like public meetings to gather feedback. There was a lot of going on to produce this task force and also to produce a report. So in that report, 2007, and I put all the links to the reports in my slides, so you can take a look of them. But there were multiple recommendations, and you can see there were a bunch of recommendations from this task force. And I am proud to say that we implemented each of them. By now, each of these recommendations have been implemented with the exception of the last three. And I think that this is important. Gather a task force of people, really like experts, trusted champions that advance, that produce a report, and then use that as a direction and to start advancing, to start moving in that direction is really important. So of course, affordable transportation for people with dementia is really hard. 21% of the people in Tennessee live in rural areas. So we don't have transportation there. It's really hard to organize that. Navigation across the continuum of care. It would be amazing to have a army of care navigators like navigating people with dementia. We don't have that yet, but we're trying to move in that direction. And of course, health coverage for persons with dementia. We're one of those no Medicaid expansion states. So it's really hard also to have those policies for our people. So the other effort that has been happening in Tennessee is the Livability Collaborative. This is an effort of 17 Tennessee state agencies that have the mission to improve the prosperity and quality of life for people in Tennessee. And this is something that we're really excited to promote, because it is led by our Office of Primary Prevention, and includes all these different government agencies. And of course, all these government agencies meet regularly, and we're talking about what are some of the risk factors related with many conditions, but also related with dementia. So it's voluntary, the participation. There is no dedicated funding. It's facilitated by our Office of Primary Prevention. It is co-owned by all the participants, and definitely there are very exciting things that have come out from these efforts. So, for example, we have an initiative which was called the Three-Star Planning Initiative. And this was all government agencies focusing on county economic development and focusing in a few counties. But the nice thing about this is, if you see that room, it was all government agencies represented thinking about, okay, what can we do for this specific county in terms of economic development? And I think that this is very important. When you have different government agencies like focusing in a few like counties and say, okay, let's do something about this together, that truly makes a difference. The other one is, in government sometimes it's really hard for people to know the services that we offer. And something that also we did, it was the Tennessee Ambassadors League Institute. So this is a specific institution that trains some government agents to advocate and to create service awareness of what are actually offering and how to encourage people to utilize government services. And in 2019, we actually had a report to kind of assess what was going on, because this effort started in 2016. And 3 years after, we commissioned to have a report to see what was going on. And one of the quotes that we received from one of the participants in this report is, "I haven't seen this level of collaboration in government before." And I think that's a big problem for us in government. Collaboration. Many times we operate in silos. So how we create bodies and groups of people that come together and start working together to benefit our communities, that's something that we need to learn. Um, and also and exercise more, of course. And we're really excited to leverage this task force in the future for something for some efforts specific to dementia. Now, the Healthy Brain Initiative, this also was led by the Office of Patient Care and Advocacy in 2017. Really important work. For the first time, it was determined that Alzheimer, it was the sixth cause of death in Tennessee. 120,000 people in Tennessee were experiencing Alzheimer, according to the estimations from in this report. And of course, in Tennessee, we're paying $7.5 billion every year in terms of unpaid caregivers and Medicaid costs. So it's really, really expensive, and of course, it's only increasing. And for the first time, also, we're talking about the big four: physical activity, obesity, tobacco use, and substance use. And I know that yesterday you guys talked about this. These are really, really important. If we're going to defeat dementia and Alzheimer, we really need to focus on this part. It's really hard in medical institutions to face Alzheimer. And one of the outputs important in this initiative, it was producing a brain health toolkit that will help people to educate others in terms of what is Alzheimer, what is dementia, and so forth, and also more coordination of different strategies to reduce those big four across government agencies and also in local health departments of health. So let's go to 2019. Now, for the first time in the Tennessee history, we have a Tennessee State Health Plan focused on aging and brain health. So this is also, that was really, really important. That was a huge achievement for us, because it was specific about dementia-friendly communities. It was specific about creating awareness and how lifestyle behaviors and early and midlife impact brain health. And also here, if you see, Alzheimer now is number 5th in the cause of death in Tennessee. And something that we really promoted in this report is the concept of dementia-friendly communities. And I know that we're gonna hear more about this concept, but definitely it is all about the healthcare that it needs to happen to screen, to start treatment, and also to do follow-up for patients with dementia. And it's about how the residential settings are informed to provide the best care to people with dementia. It is about creating legal systems and financial plans that help people with dementia. If I remember with my grandpa, something that it was really hard, it was all these services that were like designed for people without dementia are really hard to. I remember that my grandpa would start driving and then get lost. And we didn't have, it was really hard because, of course, we wanted him to be independent. And at the same time, it was really scary to let him drive by himself. And I think that this is something that when there is no services informed by these kind of frameworks, it's really easy to see how caregivers and patients itself experience a lot of suffering and pain. And one of the things that also came from this state health plan, it was this toolkit. And this toolkit, it was the result of the Patient Care and Advocacy Office in conjunction with the Health Planning Office and also with the Office of Minority Health and Disparities Elimination, having listening sessions and actually asking to the public, what do you guys need? What do you guys need from us to support your work around dementia, and also to see what services you guys need? And one of the things that came out of these listening sessions is, guys, we need more information. We need a toolkit to be able to talk to business leaders, to talk to the public, to talk to government entities, health providers, how we can create strategies to deal with Alzheimer and dementia. And this is what this toolkit is about. I really recommend you to go and look it up and see. if this is something that might be helpful. Now, it's really exciting. In 2019, for the first time after this was a recommendation of the 2007 report, we created an Alzheimer's disease and related dementia advisory council. This was mandated by the legislative. Is a lot of the work that happened to make this happen. It was led by the Tennessee Department of Health. And of course, this is, you see that we have representatives from the Tennessee Senate, from the Tennessee Commission of Aging and Disability, Thank Care, Department of Mental Health and Substance Abuse Services, and so forth. And it was, let's see what are the trends of Alzheimer in Tennessee. Let's examine all industry services and resources for the specific needs of people with dementia. And let's develop a state response for this problem. Uh, and and also there were a bunch of recommendations for the governor and the General Assembly and issues related to work and dementia. And of course, you can imagine it's 2017. Then the next year we have the pandemic, and unfortunately, many of the efforts that were like promoted slowed down a little bit. But one of the things that actually came out of this is we have an Alzheimer and dementia respite care program that provide home and community-based services to people in Tennessee. And this is something that is being piloted, and it was the result of this. And of course, this advisory council keeps meeting and producing reports every year and recommendations. And I think that this is really important. And finally, in 2022, this is the Tennessee Department of Health put together a healthy aging steering committee. And that was mainly to align and increase cross-division collaboration and promote healthy aging and cognitive health across the lifespan. And we have the Department of Health, we have different divisions, different offices, and we are trying to make sure that anything related with health promotion, it has something around dementia. It has something like that is really create awareness about this disease, and also how to approach it and what services are available. And a few examples of this integration of promotion messages is, for example, the chronic disease prevention program is working with the tobacco prevention messaging also, and so forth. So there is this way of bringing together different messages and say, guys, dementia is also important, and try to pair that up with other important services in the state. So I'd say dementia, when I think in dementia, this is one of the biggest challenges of this century. So in Tennessee, we're going to have around 37% of our population is going to be above 60 in the next 10 years. What happened to the US, to France in hundreds of years is going to happen to the US in a few decades. This is really, really concerning. And as I mentioned, I'm a physician myself. Challenging and dealing with Alzheimer and dementia in healthcare settings is really hard. We definitely need to be thinking in policy. And I think and you as like government employees, you have a lot of agency and a lot of voice to really advocate for this topic. So thank you so much, and looking forward to the conversation.
Thank you, Hector. That was great. Collaboration is key, no matter what you're doing. It takes a village to raise a child. It takes a village to pass and implement a policy as well. So our next speaker is Sarah Locke.
Thank you all. I want to take a few moments to thank our organizers, the CDC, the Alzheimer's Association, for an incredible meeting. Every panel that I have listened to has been so exciting. I've learned so much from this panel as well. It's just a fantastic opportunity to bring this community together of people who are so passionate and caring about this topic. It's fantastic, and I thank you all deeply for this opportunity. I also wanted to say, to the point of evidence-based policy, I was asked to focus on livable communities, and I believe that livable communities are the way to sustain brain healthy behaviors. So I'll do that, but I wanted to start a little bit with describing some of the evidence that we at AARP are relying on and have built upon in order to move to a place where legislation and public policy are possible in the areas that we all care about. ARP, you may know, of course, is working on the national, international, local, and state levels. It is really powerful when all levels of policy and legislation work together and influence each other. Of course, ARP's work on the Affordable Care Act and with prescription drugs, these are things that people know a lot about because it's big and splashy. But you may not know as much as ARP's work on the state and local level. And when we can't make progress on the national level, a philosophy is our states and our local areas are the seedbeds of democracy, right? This is where you can actually get things done that matter to people. And so I think you'll see throughout the presentation that theme, that using evidence and whatever levers at wherever you have an opportunity to be arguing and supporting these important points make a lot of difference. And if they work together, that's best of all. So we first start with research. What do people 50 and older or adults care about? And we're constantly surveying them to ask, what are the things that concern you most? And you might guess the future of Medicare, the future of Social Security are the top two issues. But tied with that is the ability to stay sharp as you age. Now, ARP's been in this business a long time of helping older people, and so we were all over Medicare and Social Security, have been and will continue to be, but we hadn't really been focused on brain health until about a decade ago. So when we did the survey, we found out 98% of people in a nationally representative survey oversampled by population groups. Adults 40 and over believe that brain health is very important. That's almost everybody. Don't you wonder about the 2% that don't? But when we ask them, are you exercising? Are you eating right? Because, everybody knows they should be healthy and they kind of know what they should be doing. The Heart Association has been at this 100 years. Yeah, people know that they should exercise and eat well. But only 56% of them report they're doing the things that are good for their brain. I really doubt that number. There is no way that 56% of the population are getting the number of minutes they're supposed to or eating right. But let's go with that. Let's give them the benefit of the doubt. So what did they say? What stops you from doing it? Not knowing what benefits the brain and the people around me. Because what my friends are doing, my family is doing, that's what I'm doing. So we set out to try to simplify the messages about what is that people could do to protect their brain health. ARP's mission is to empower people to choose how they'll live as they age. Our mission was to empower people to have a healthier brain over their lifetime. And so you'll see with the circles, we founded the Global Council on Brain Health to do a deep dive into the science and talk about what the evidence shows in all of these areas. And we created Staying Sharp, a digital platform, so that no matter where you lived, you could get the information in how you could maintain your brain health. It's a digital platform, so it's rural, it's urban, it's wherever. And so Staying Sharp, I'll tell you a little bit more about that later. But we condensed the findings of the esteemed Global of Councils. We have experts from all over the world who work in the areas and ask them, what's the science? What's the randomized controlled trials? What is the evidence behind it? What would you give your Aunt Sally, for information? Because we can't wait until we have perfect knowledge. Let's find out what we've got and let's move on the evidence that we have. And so those two things have centered our policy and our legislative efforts around this. But first, we're trying to provide that information of what works. And so here is a very simplified way of describing what it is that we're asking people to do. We can't ask them to do everything. We surveyed them. And if you throw all of these things at them all at once, it's too overwhelming. So our advice was to start small, keep it simple, give them the information that they need. And this, of course, is based on 50 pages of reports on each topic, where we gather all the experts together and ask them to come to consensus. So we've been looking to figure out how to take this knowledge and actually implement it. And I want to thank Lisa, I want to thank Matthew, others here who are liaisons to the Global Council on Brain Health, because we want to make sure that when we issue these enormous reports and the one-page infographics available in 5 different languages, that it's actually something that's not going to confuse people. Because if the government's saying one thing, and the Alzheimer's Association is saying another, and the Heart Association is saying another, it's very confusing. What should people do? So we're trying to drive consensus, and through these last 6-7 years, 13 reports of getting the consensus of make it simple, make it clear, make it understandable, and then we can move from there. That's what the Global Council does. We've got 13 governance members, but now over 28 countries and 150 universities and organizations. Talk about bringing people together. And I want to give a shout out to my colleagues, Dr. Lindsay Chura, who is the Chief Scientific Officer of the Global Council on Brain Health. I have to, the Nevada team was here, and they called out Sarah, Sean, and Sarah, and I want to add Miss Carson. So I want to acknowledge that it does take a village. But we were looking at how do you actually drive these behaviors? Because it's fine to say, yes, go exercise. How do you get people to integrate it in their lives and not just do it for one day, but how to sustain it? So then we got all the behavior change experts in the world together, and they said, look, it's not just the simple you do it. You have to create systems. That's what you all do. You have to bring these systems, individuals, communities, and policymakers together. And then you work at each level and you drive your points through each of them. And then you get surround sound and you create the systems in which people are able to implement these healthy behaviors. And so that is our behavior change report, which is the latest. And in order to actually help people, how do you make it easy? How do you hit the easy button so people can eat right, so that they can engage their brain, so that they can be socially connected? You have to build your communities, and we have an urgent problem. It's actually, Hector, I disagree with you. It's not a problem. It's a fabulous thing. Because of public health, we are living longer than ever. And yes, age is the greatest risk factor for dementia, but we should be celebrating that and saying, we've achieved so much. Now we have to deal with these issues. But when by 2030, 1 out of 5 of us is going to be over 65. By 2035, people 65 and older, there's going to be more of us than there are 18-year-olds. And by 2050, the number of people, if we don't get our stuff together, we're going to have 13 million people that we have to provide services for. But we can cut the incidence in half. Yes, we can cut the incidence in half if we can delay onset just by 5 years. So we have a big mission, and it's not just us talking about it. The Population Reference Bureau talked about the neighborhood features that play a role in healthy aging. And they have been saying that we can slow cognitive decline if we have plentiful resources such as parks and libraries. We don't have to only be thinking about how do we give the information to the individuals? Instead, we have to think about how we're going to reform our communities so it's easy to get out in nature and do what we're recommending. So ARP, based on the World Health Organization for now probably more than 20 years, has been working to create age-friendly states and communities in which health is a critical pillar. There are currently 745 communities. That changes all the time. States and territories enrolled. If you are not living in an area, come talk to me later that is age-friendly. I have a slide later on. I see that I'm running way late, so I'm going to have to start to breeze through this, where we talk about the relationship of age-friendly to dementia-friendly. And AARP wrote, better together. It's better to implement these programs together. An age-friendly state is where elected leadership in community has made a commitment to work with residents and local advocates, or to live and to enroll and meet the 8 domains of livability. Again, the slides will be made available, but you can see when we're talking brain health, we're talking transportation. When we're talking brain health, we're talking housing. When we're talking brain health, we're talking about outdoor spaces. This is what makes it easier for individuals to implement the recommendations that we're trying. And yes, respect, social participation, communication, and information and health, those are things that we've been talking a lot about. But civic participation and employment actually make this critically possible for communities to actually engage in these healthy behaviors. So the livability index, I'm down to 19 seconds and I've got a few more slides, but I'm going to race through. But what's important about this livability index, it was designed to motivate state and local changes in policy planning and investment, and to inform key stakeholders and encourage community participation in how does your community rank in the livability scale. And that competition actually is very healthy, because if San Jose gets a better rating than San Diego, then they're at each other to try to up one another. That's the American way, right? But we wanted to provide them the information so that you could see how livable your community is. I urge you to take arp.org/livability index to measure, and you'll see across each of these measures and these characteristics how your community fits in, and see what your score is. The idea is you can choose to live in communities that will support a livability as you age. I have the video, but I'm not going to show it because I'm all out of time. And I will, it's on ARP's website, and when you get the slides, you'll get that. Just a quick closing, you'll see here, when you get the slides, the relationship between dementia-friendly, which are 10 sectors, and WHO ARP age-friendly 8 domains, and the factors of which the livability index is looking at. And finally, June is Brain Health Awareness Month. ARP's Staying Sharp is available, and there's a cognitive assessment to give you a baseline so that you can kind of figure out where you are. And that assessment is going to be free in the month of June. So if you're an ARP member and sign up for Staying Sharp, you can get it as long as you are a member for free for the rest of your life, so that you can see how you're doing with exercise, so you can see how you're doing with diet and cognitively stimulating activities and those 6 pillars of brain health. So thank you very much. Appreciate the time, and on to the next speaker, another Sarah.
Thanks, Sarah. And I encourage you to all look up all these links and take the time to really explore some of these resources, because they're great. All right, next up is Sarah.
Good morning, everybody. Thank you so much for having me today. And thank you to my colleagues here who gave us some really nice examples about how we can work together to implement policies that will ultimately promote brain health and also reduce the risk of dementia. So I'm going to wrap up our panel discussion today with the goal of trying to help you find out or discover your role in the advocacy process and in policymaking. So I bring a lens of my training in law and public health to the table, and I've also found myself in the space of practical training. I work primarily with undergraduate and graduate students, and one of the things that I really try to impart on them is to really identify what their role is in this process, because together it will be important for us to make change. At the end of my slides, I have some resource slides. And those slides are really intended to help you get some tools and to see some examples of different policies and the policymaking process. So I'm not going to go over them, but when you do get access to the slides, you'll have them. Some of those resources are specific to California, but you have similar resources in your states as well. So I want to start with a story, and this story is about Fred. So Fred leads a pretty sedentary lifestyle. He also is suffering from depression. And at a recent doctor's visit, his doctor told him that he actually has prediabetes. So the doctor and Fred came up with a plan together. He was prescribed a medication for his depression. He was given some counseling over healthy eating and improving his exercise, and then also given some tips on healthy sleep behaviors. But what happens to Fred once he leaves the doctor's office? What's in place to make sure that he's able to follow the plan? Well, as you all know, and as we talked on the panel today, it gets a little bit complicated once Fred leaves the doctor's office, right? So is he going to be able to afford his medication? Does he have access to fresh fruits and vegetables? And are those vegetables and fruit affordable? Did he even understand the directions that the medical provider gave to him? If Fred is working, how is his job going to influence his ability to follow the plan? Let's assume Fred has children, right? Who's going to watch the kids when he's going to exercise? What does his family think about it? If somebody in his family is the one doing the cooking, are they on board to ensure that his diet is going to be healthy? And then also, what are the cultural influences? But really, really important to this is, are there policies in place, and what are those policies in place that are going to make it either easier or harder for Fred to achieve his health goals? So when we think about something as big and as complex as risk reduction and risk reduction with respect to dementia, it can really feel overwhelming. But by seeing the full picture and then coming up with concrete action items and plans, it can start to make it a little bit more feasible. It's important for us to be leveraging resources throughout this process, and those resources could come in the form of existing efforts, expertise, and also infrastructure. We can collaboratively work together to decrease the risk of dementia and to promote public health. So who here has heard of the concept health in all policies? Okay, great. A lot of times when I talk to undergraduate and graduate students, they have no idea what health in all policies mean. And for those of you who aren't familiar, the idea is that we really want to infuse health in all policies, even if they're not directly related to health. So for example, if we think about tax law, zoning regulations, or even educational policy, we really want to make sure that health is infused in there. So we often think about legislation when we're talking about policy change and creating policies that's going to reduce the risk of dementia. But while legislation is critical, I really want to stress that it's only one policy strategy that we can use to promote brain health. There are lots of other strategies as well, and I have them up here on the slide. So we really should be considering the role of government agencies in this process. In public health, so much of our work is dictated by regulations. So let's put in place regulations that are going to reduce the risk of dementia. How can agencies create guidance that are going to be promoting brain health? And then also, how can we use enforcement actions, again, at the administrative level? Has anyone here contributed to writing a public comment for a proposed rule or regulation? Okay, so a few of you, right? This is a really concrete way to get your voice and the voice of your organizations and your communities as part of the policymaking process. And I do have a toolkit in the resource slides to help you think through what that process looks like and how you can contribute. So we've also seen significant health policies made in other settings as well. So think about executive orders. These were really used well during pandemic response, for example. We've seen health policy changes being made through the judicial system. So you can think about Dobbs and Roe v. Wade. We've also seen significant health policy changes through ballot initiatives or propositions. So in California, for example, legalization of marijuana came through a ballot initiative. And yesterday, importantly, we talked about at the organization level how we can have policies in place to promote brain health and to reduce the risk of dementia. And at the heart of all of these advocacy, at all of these policy efforts is really that idea of advocacy. And we need to use advocacy in all of our work in order to promote brain health. So I think this logic model is really helpful in conceptualizing this, and we talked about it a little bit in the beginning of the session. So this is at the level of law, but you could easily swap in any type of policymaking process in its place. So the idea is that you have the process for creating the policy, then you have the policy itself, and then you have the practices that implement the policy. You see, a law on the books or a policy on the books is literally just that. It's a policy. Without the enforcement and without the implementation, we aren't going to see changes in health behaviors and in population health. So those implementation practices then will lead to changes in environment or to changes in behavior or possibly both, and that will ultimately have an impact on population health. So how do we get there? I'm going to drive home this point again. It's through advocacy. So I like to think about advocacy as a toolbox. And in that toolbox, we have a number of different tools that we can use to affect change. It could include research, education, outreach, coalition building, community organizing, writing, policy drafting, among others. And then let's think about the process itself. So in the beginning, it's really important to identify and frame the problem. And science and research can really help us do this. This is really particularly important when we're talking about something as complex and also abstract as reducing risk. Because for some, especially decision makers, it might be hard for them to understand. So we really have to do a good job of focusing in on how we identify and frame those problems and then communicate them to decision makers. We can bring in stories, our experiences, personal or professional, and also our research and community voices. We also need to then engage communities and identify stakeholders. We've talked a lot about this throughout the course of this conference so far. We need to assess then if there's readiness for change. And what do I mean by that? So is there the political will with the decision makers? Is there community support for this? And if there's not, then education can really be helpful in raising awareness and creating that political will and readiness for change. And then you'll notice that the process doesn't stop once the policy is written and adopted. It's really important that we're focusing also on the implementation and evaluating the impact of our policies as well. Coordination, collaboration, communication, frequent process evaluation, and also negotiation are all critical in this policymaking process. So let's talk for a minute about collaboration. As I said, we've seen throughout the conference a lot about ways that we can collaborate. And one of the things I loved about what my panelists have done so far this morning is really say, here's an opportunity for us to work together. Come talk to me if this is of interest to you. And I encourage you as you're continuing on throughout this conference to really find those opportunity spaces and find ways that we can work together to promote brain health. So yesterday, we also spent a lot of time talking about partnerships. And I have to give credit to a student who took this picture as part of an advocacy fellowship that I run. It's really important that in our work creating partnerships to create policy change and to promote brain health, that we're really taking a look at who's at the table and ensuring that we have diverse partners representing different disciplines, sectors, and also racial and ethnic groups as well. And so another key group that I encourage you to think about as my role as an educator is really the future public health workforce and students. We want to bring those students in to get practical training and to get guidance so that we can create a workforce that's ready, able, willing, and also inspired to address dementia risk and also to promote health, brain health. And together, we can really raise the voice of communities and make a difference on these policy levels. So it's really important to leverage existing efforts as well. And you can look for different resources such as experts and organizations, model policies, model legislation, guides, among other things. And Change Lab Solutions is one organization that has a wealth of resources related to creating healthy communities. Within your communities as well, it's also important to identify different opportunities to leverage resources. And shared use is a really good example of this. For those of you who aren't familiar with shared use, it's when usually a government organization, but also could be a private organization, decides to come up with an agreement to allow community to use their space. And in a lot of shared use agreements, it's an opportunity for folks to engage in healthy activities that we know will promote brain health and reduce risk of dementia. If efforts aren't well coordinated, we run into a little bit of a problem because if we don't have the clear outcomes and clear goals, then all of our advocacy efforts and our work towards policy change can really be in vain. And one of the things that I love about public health and that you're all so well trained to do is to bring in diverse perspectives to really come to the table and represent multiple sectors. And I want to give you an example here. This is an example from UCLA Fielding School of Public Health's Proyecto Mercado Fresco project. And as part of that project, they went out and converted corner stores to become healthy marketplaces. But what the team found was just by converting the store to be a place to shop for healthy fruits and vegetables, it wasn't enough. It didn't ultimately change healthy purchasing and also healthy eating. And so what happened is they played this really important role of coordinating different efforts and getting the community engaged. And a social marketing campaign accompanied the intervention. And this is a sample of a bus poster that was part of that project. One major success of that specific program was the engagement of different stakeholders and in particular youth. When we look at this young generation and we find ways to get them involved and excited about healthy eating and other healthy behaviors, it can be really helpful in creating sustainable change. And throughout all of the examples that we've heard today and also the ones with Proyecto Mercado Fresco, communication is really key. I think that the pandemic highlighted for us the need for better communication within the field of public health, right? And we've talked throughout this conference about how important it is to find the right messenger to deliver the message to different audiences. And the same is true within the policymaking process. So I'm going to give you a few more examples as I kind of close out my remarks for today. We really need to focus on engaging communities and having communities hold government agencies accountable for different interventions with a specific focus on health equity. And this photo and caption was written by a Master's of Public Health student as part of a campaign where they collaborated with an organization called Los Angeles Walks, as well as a marketing firm or a social marketing firm. And on the ground, they were trying to raise the voices of community members who had unsafe streets. Government agencies simultaneously were working on policies to create safer streets with this idea that if we can create more walkable communities and safer streets, then we can ultimately promote health. So when we can't legislate, we can also try to regulate, and sometimes we have to litigate as well. So who is familiar or remembers the sugary drink beverage cap rule in New York from some time ago? Okay, so a pretty good number, right? So in that case, for those of you who aren't familiar with it, the Board of Health in New York decided it wanted to kind of cap the amount of sugary beverage a person could buy in a single serving. Ultimately, it was met with a lot of opposition. So there were ad campaigns, as you can see on this slide, and there was a lawsuit that followed. Ultimately, it was found that the Board of Health exceeded its regulatory authority in creating that rule, and so the policy intervention failed. But what it did do is it raised awareness about the issue, and it potentially moved the needle on the political will to create policies at other levels that could really address the issue. So when it comes to prevention and specifically risk reduction of dementia, we're probably going to be met with some opposition. And we heard some examples about that earlier today with industry as well. And we need to be prepared to both respond and also safeguard policies that we put in place. And I want to give you a final example today of a comprehensive advocacy effort through Mazon, a Jewish response to hunger. So the image that you see here on this slide is of a truck. And it's a truck that converts into a museum exhibit. And this truck, pre-pandemic, traveled the entire United States, bringing hunger education to communities across the country. Oopsies. As part of the campaign, research really supported it. And you can see here an example of an infographic. By using data and communicating the data, we can really create compelling arguments. They also had a photo booth with the idea of the museum exhibit was kind of capturing an audience, and that audience has community and they have networks. So by using the photo exhibit, they were able to spread the message around hunger. And then there was also concrete action steps as well. So at the exhibit, they had tablets where people could sign up for action alerts, and then they could also send a letter right there on the spot to their elected officials requesting change. And one of the most powerful exhibits, at least in part of the exhibit, at least in my opinion, was the use of storytelling to communicate. When you're talking to decision makers, numbers are really important, but so is the story and putting a face to the story and a face to the issues. And so take Mark, for example, one of the folks who was featured as part of the exhibit, who is a veteran and had trouble finding employment once he came back due to stigma around PTSD, as well as a changing job market. Mark had to skip meals in order to feed his baby. And so using these stories can really help us. And there's an amazing video that they have using photos and also voices to encourage you to advocate for change. And then most recently, they launched a virtual museum, a virtual hunger museum, with the idea of if we can learn about the past, we can change the course for the future. And so I like to think about advocacy as a spectrum, and we all have different roles to play on that spectrum of advocacy. I encourage you to think about where you and your organization fit into this spectrum and to find a way to work together to create change. Thank you.
Thanks, everyone. And now we will open it up to questions.
Stand up and do jumping jacks.
Over here. Oh. Tech guy's coming.
Thank you. Hi, I'm Kristen Felton from Wisconsin, and this is a question for Dr. Caruso. I noticed that you had, it looked like most, if not all, of the other departments in the state involved in your state plan. So I am wondering two things. First, is the governor a sponsor of your state plan? Is it considered one of his initiatives? And if so, are you concerned about future elections putting power into the hands of the other party who may have no interest in continuing any of the initiatives of the current governor?
Thank you so much. Okay, now this is working. Well, thank you so much for that wonderful question. And, you know, when it comes to policy change, this is some of the things that we need to have in mind. And I'm so happy that you're bringing this up. It is true that the state health plans are at work and leverage in conjunction with the Tennessee Department of Health and other government agencies. And this is something that we have, the state health plans is something that has been happening for years. It's nothing related to the governor specifically, but the topic, like focusing on agent, it was something that it was leveraged by multiple constituents. So it was the Tennessee Department of Health, it was the ALZHEIMER'S Association, and it was many other organizations locally, like putting some pressure to leverage the political power to make this state health report specific about aging. And this is when the organizing works, it really produces a benefit, because I am of the idea that that state health report created the momentum to advance this idea of the Alzheimer's disease and related dementia advisory council. So I think that this is how you mobilize people. I think that once that you put a report out there and say this is what is happening in Tennessee, this is how many people experiencing Alzheimer's, this is the economic cost, because there is a moral cost of people suffering, there is an economic cost of how much it costs and caregiver costs, and also in Medicaid costs for us, or like healthcare related costs. And there's a political argument too, because everybody knows somebody with dementia. So for instance, it is political leaders are interested in these topics because they know that for them, addressing these concerns, it represents votes in the future. So I think definitely creating these arguments is really important. And yeah, and we are, democracy is something, in a democratic state, of course, we know that some of the effort that you advance eventually come back if you don't have some leadership there. But definitely creating the awareness in your community, I think it becomes so important, so that they protect whatever you advance in this setting. And I think that is something that we have truly tried to do in Tennessee. And I think that the advisory council is something that is not going back, for example, because there is so much support for that. But thank you for that question.
Can I jump in? I want to, boy, it's loud. I want to emphasize something Amy said about the importance of the bipartisan nature of the approaches that we take. It certainly is possible when you are looking at any of these issues to think of it as particularly Republican or particularly Democratic or particularly one way or the other. But anybody who has an interest in economic well-being, anybody who has an interest in moral well-being, anybody who has an interest in succeeding in their family, ARP represents older people, and we tend to be the voters tend to be a little bit more conservative in nature, and the bottom line is, over the years, in so many legislative battles, either state or federal, if it's bipartisan in nature to begin with, if it's using the good sense and the evidence, we found over and over again that these things actually are sustainable. Now, there's no doubt that over time there's some big losses from a legislative policy perspective that change over time. But fundamentally, if you approach the issue as a bipartisan issue and you don't put all of your eggs in one basket, it has tended toward justice, frankly. I will just say that as a lawyer and as an advocate for over 30 years operating in this space. No matter the political environment, fundamentally, evidence and rationality of self-interest often wins out.
Great, thank you. Over here.
Hi, Anita Balan, American College of Preventive Medicine. Great panel, and I may have a wonky question for the moderator, Dr. Eiler here, and others also feel free. I'm wondering, because you talked about the predictors and the various legislation, I'm wondering, have you looked into legal epidemiology, taking a look at the legal data sets, converting that to analyzable data to look at what's the effectiveness of laws and policies, particularly when it comes to physical activity? And I'd love to hear Sarah Blenner's response to this as well, in terms of the advocacy strategy that and the public health workforce that you're training, and whether you think this is going to be a useful tool, particularly when it comes to legislation looking at risk reduction for dementia. Thank you.
Great question. And I have a doctoral student who is one of the only legal epidemiologists who's JD and PhD. And so working with her really helped me understand this. Back when we did this, it was still really emerging about that. So in answer to that study, no, we didn't do that. But that is super important right now as evidence is building and emerging, and we can put the measurable outcomes, the epidemiological outcomes, into our policy work. So stay tuned, because I think it's a really hot topic right now, and will really help our efforts. And Sarah, did you want to comment on that?
Thank you so much for that question. It's really important to be doing the research to understand how the policies are put in place. And if you're not familiar with the Public Health Law Research Center, I highly encourage you to check it out for everybody as well. They have a lot of really helpful, useful guides on how to design research and how to really measure the impact of policies. But I do think it's going to be really critical moving forward that we invest efforts in understanding the role that these policies plays, and then also on the reduction of risk. Thank you.
Can I just add to that just a little bit? I want to first of all thank you for your question. You know, we've at the American Heart Association been working with CDC just to pull a collaborative conversation together around implementation and outcome evaluation. I'll tell you that as an organization that's evidence-based in our work and has a broad advocacy portfolio, we want to measure the impact of what we're doing. Well, we've been doing it by counting, one of the ways, by counting the number of pieces of legislation or regulation that we're working on and that end up enacted. That is just a little bit of the picture, and what we're starting to now think about as an organization. Can we better understand the impact of the policy that we worked on? So we're starting to look at things that the legal implications of, basic questions. Was it fully implemented? Was it resourced adequately? Who are the stakeholders that came together to make it happen? We cannot do that alone. We have to do it in partnership with public health agencies who are doing that kind of surveillance on the ground. And we have to bring appropriations and funding to that work. We have to bring researchers collaboratively together. And I believe we have to build out an evergreen research agenda around policy implementation and outcome evaluation. We are not doing nearly enough as a field to understand if our work has created disparities, improved disparities, been impactful, et cetera. I think it's the frontier of our work in policy right now, and it feeds back to informing model policy. We have to understand if what we did made a difference.
And I do have to say that I'm so thankful that the next generation is being trained, because policy work, it takes so long. I might be retired before the time that we see these outcomes, because think about the process, agenda setting. We think that being enacted is a win, but that's only the first step. Sometimes in that enactment is a date when it's actually going to be implemented that is years beyond the enactment date. And then there's funding, and then so it really takes a long time. So, but it's on our minds now, and there are resources. So I think we're really in tune to measuring those things.
Hi, it's Marsha Ori from Texas A&M. I think you've answered my question, but I was so excited at the beginning to sort of hear the whole policy process, and at the end to hear about advocacy. But I'm a state employee in a conservative state, and we know we can't advocate. We know we can do research, so it's sort of, you feel a bit boxed in with what you can do from your heart and then what you can do as an academic. So I would love to hear a little bit more about academics and how they sort of navigate that role between heart and restrictions.
So I'm just going to jump in right here, and I'm going to challenge you, because I actually think that government employees and government actors have a really, really important role in the advocacy process. So sure, you're not going to go and lobby an elected official, but the role that you're playing in a government agency is really critical in setting the course for policies, how they're implemented, and how they're affecting communities. So when I started doing work in higher ed related to advocacy training, there was a lot of stigma around advocacy, and that's why they brought me in to launch an advocacy training program. But over the years, the incoming generation of future public health professionals really have this focus on health equity, health disparities, and advocating for change. And so I think we need to change, as the existing public health workforce, our perspective of what is advocacy and what is our role. We need to think about it as we're designing research questions. We need to think about it as we're analyzing our data, because all of that is going to be instrumental in how we ultimately frame, identify, communicate, and advocate for change.
Can I say something? I love your question because, so I would say that my relationships are at the national level primarily with federal agencies. And I just want to say how much I value the career professionals that are in those agencies and do this work across administrations day after day. And partnering with organizations like ours, and creating that stakeholder kind of collaboration is critical because there are things that we can do. We can advocate for you for your appropriations and so forth, and we do that. But we can also communicate to you what we're hearing from our field advocacy. What are the questions we're getting on issues, and what kind of research do we need to fill the gaps to fix some of this? And so that two-way communication is really, really important. And so I am privileged to have some of those relationships with some of our federal agencies. And I will tell you, it's a bi-directional relationship. It's a bat phone kind of conversation. I can pick up the phone and talk to them. And sometimes we'll say intentionally don't put things in writing. We do things by voice to voice just because I don't want to get any of my, those federal agency colleagues in trouble. And they often will communicate to me things that are kind of front of mind for them. And those relationships are critical, and supporting each other is so important. But in a bipartisan way across the political landscape, I would just encourage you to build those relationships and help each other. It's just a matter of support.
And if I might add a few things, is something that we can do as government employees is we can have teams and groups of people working on a specific health concerns. In this case, for us, is the patient care and advocacy office. So we have a specific team to focus on this. The second thing is we produce reports that help to ground the conversation, to provide evidence. This is what is going on in our counties. This is the impact of this condition in Tennessee. And then we educate the public to say, guys, this is a real concern. This is what is happening. These are the symptoms and the signs of this condition. Let's do something about it. And then if we do these three things right, then we're going to start educating the legislative body. And this is the experience in Tennessee. At some point, we did this thing right, these different steps, and at some point, we were talking to the legislative. Okay, what is next? Let's create an advisory council and let's advance policies specific for this condition. So sometimes I know it is hard as government employees. We feel that we don't have any power in the process, but we do have a lot, and people hear our voice if we speak up. And unfortunately, this is not a polarizing topic yet. Everybody agrees that providing care to grandpas and grandmas is the right thing to do. So it's not that hard to talk about it.
Just to gild the lily a little bit of what Hector's saying is that the power to convene and to create coalitions and support coalitions is absolutely incredible at the state and local level. And that is a totally bipartisan, non-specific, apolitical act, which can move mountains. Not only the power to convene, but as we were talking about, I think Alan was talking about community needs assessments, unbelievably powerful, and you can have a conversation with a reporter and you can change it overnight. So you have incredible power, and I hope you use it.
Great, thank you. Next question.
Good morning. Great presentation. Guadalupe Ayala, San Diego State University. So I've had the pleasure of being able to work with partners who are implementing small Ps, like Dr. Eiler said, organizational policies. This is after years of being involved in intervention work and feeling like nothing gets sustained, even though we get those health behavior changes or even health outcome changes long term. And I'm curious, and kind of what you already mentioned to the last question, I think is relevant, but if you can add anything, how do we then elevate the conversation either to the county level or the state level to start thinking of the bigger Ps? Is it about sharing data, like you said, Dr. Carrasco, or is it, and what kind of data? Is it adoption and implementation of the policy, or is it the impact data, or is it all of it? So they're very interested in figuring out how to elevate what they've done at an organizational level to more at the county level.
I think the first key is even before that. Everyone has to be using the same measures. We all have to have this cumulative data and evidence that these things work. So if several places have a similar policy but aren't measuring the same things, then that information may take a different course. So I think that's the first step. And you think that's easy. It's really not. In the physical activity realm, we argue about it all the time. Mm-hmm. But so I think that is the first step. But does anyone else have anything to add on that?
I love it. So, we have presence at all levels of government in our advocacy work, local, state, federal, and global. And so, like Amy said, to coordinate across that, and others have said, to coordinate across that work is really valuable. We can help bring the small p policy to larger p legislative regulatory work, but it is working in partnership and coalitions and collaboration. But it's also building up, taking what you've learned at the organizational level and building it into model public policy is a process. And, working with those who do that every day, would be another first step, bringing the evidence base to it. And it depends on the issue, what kind of evidence base you need to bring. One thing I'm working on right now is on the payer coverage kind of strategy. For that, you need to bring cost savings data. You need to bring economic data. Sometimes you need to bring health impact data. Sometimes you need to bring equity impact data. It depends on the issue and what you're trying to bring to scale. But it would be great to work in collaboration and coordination to help support.
And just maybe to add a little bit, I think at first is about framing that this is a condition, this is a disease, and it is not okay to age with dementia. So that's the first thing. The second thing is, what is the incidence and the prevalence of this condition? It is in which counties specifically. I think that's also really important. Something that we have been doing in Tennessee is county-specific profiles, health profiles, that show what number and the list of causes of death like Alzheimer's represent. So this is important also for policymakers at the local level. And then projections. Nothing is more scary than say, by 2030, this is the amount of the population that is going to be about 60, and these are the amount of services that you're going to have. Let's do something about it now, so there is no a larger problem later. The other one is risk factors. That people need to understand that there are risk factors for this condition, that if we address those, and actually in the Healthy Brain report, we determined that the big four, if you eliminate those, you can have a reduction of 30% in the incidence of dementia, which is huge. So it's like focusing and also on risk factors, and then providing some specific wins if they act. To local leaders, they love that. It's like, if I act, these are the benefits. This is what you can see in terms of benefits politically. And these are also the solutions that you can implement. So I think being a little bit prescriptive always help. Because many times you don't have people very knowledgeable about health. So sometimes being a little bit prescriptive, you focus on this and this and this, and you can get these benefits. I think that might be helpful also in your setting.
I think too, telling the stories. So we get so caught up in the evidence space. I do it all the time, and I have to get reminded by our advocacy communication staff and our grassroots staff, please help us tell a poignant story, take that evidence base and translate it. And that's what moves policymakers, honestly. We can bring them the statistics, and those are incredibly important and valuable in informing our work. But we also have to create the poignant story and bring the storytellers to the conversation. We're increasingly trying to incorporate more lived experience and those with lived experience into our work and get better at that. We have a lot of learning to do there and to try to improve our work in that space.
Thank you. Any more questions? All right, doesn't look like it. So I think we can wrap up by doing about 10 jumping jacks. No, I'm just kidding.
That's the joke of the day.